Assalamu alaikum warahmatullahi wabarakatuh. So this will be the last part of hyperthyroidism. So let's finish this topic of hyperthyroidism. Let's begin with the name of Almighty. So treatment table, drug names, dosages, and contraindications. So these two are thionomides, and this is beta blocker. So methimazole, dosage is 10 to 30 mg per oral daily, and maintenance dose, this is the starting dose for induction. Maintenance dose is 2.5 to 10 mg per oral daily. And remember, if the dosage is less than or equal to 10, give it once daily, and if the dosage is going up more than 10, then divide the dose. For example, like if the patient is given 30 mg, divide into 10 10 10, morning, afternoon, night. If it is given 20 mg, then divide into morning and night 10 mg, like that. Okay. So what is the mechanism of action? Inhibits the thyroid peroxidase. Side effects, this is important. Okay. Pruritic rash, joint pains, arthralgia. Most important side effect to remember is abnormal LFTs, cholestatic pattern. And second most important is agranulocytosis. That means you should monitor the patient's CBC and LFT. LFTs should be monitored in methimazole. Okay, CBC and LFT. Okay. So what are the contraindications for this? The first trimester of pregnancy, it is contraindicated by high risk of teratogenicity. It can cause aplasia cutis, meaning skin will not be developed, or choanal atresia. Aplasia cutis or choanal atresia. That's why it is contraindicated in first trimester. So propyl thyrosol, starting dose is 100 to 150 mg per oral. But in cases of thyroid storm, the dose is doubled actually. Starting dose is 200 mg to 400 mg per oral. It is given as thrice daily TID dose. Okay. And in thyroid storm, because the patient may not be able to take it, you can even give it via the nasogastric tube also. Again, same mechanism. It inhibits the TPO as well as it inhibits the 5-deiodinase enzyme peripherally, that results in inhibition of the conversion of T4 to T3. Side effects, again rash, ANCA positive vasculitis. This is the most important side effect of this, that is fulminant hepatic necrosis. Okay. So again here also you should monitor CBC and LFT. Here it is agranulocytosis and LFT. Okay. So that you should remember. So what are the indications of this propyl thyrosol, PTU? First trimester of pregnancy, thyroid storm you should given. Okay, methimazole allergy. These are the three indications. Propranolol, symptomatic control, you can give it as 10 to 40 mg thrice daily per oral. And in thyroid storm, you can give it to 60 to 80 mg per oral thrice daily, TID. Normally 10 to 40 mg, and in storm 60 to 80 mg, double the dose. Okay. And IV dose is 0.5 to 1 mg IV. 0.5 to 1 mg IV. Okay. Should be given TID. IV preparation is usually not available in India. You should give oral only. So it is a non-selective beta adrenergic blocker. High doses inhibit peripheral conversion of T4 to T3. What are the contraindications? Asthma is a contraindication, severe COPD is a contraindication, decompensated heart failure is a contraindication, severe bradycardia is also a contraindication, heart block is also a contraindication, meaning cardiorespiratory condition are a contraindications. Okay, let's move on. So Lugol's iodine or SSKI. So preoperatively it is used. and also in thyroid storm. Two conditions. One is pre-operative preparation, second is in thyroid storm, to block the secretion of thyroid hormone. Okay, to block the secretion of thyroid in thyroid storm. So what is the dose? 3 to 5 drops. 3 to 5 drops per oral 3 times daily can be given, and in thyroid storm give it a high dose, meaning 5 drops per oral 3 times daily, TID, 5 drops. Okay, so it induces Wolff-Chaikoff effect, acutely blocking hormone release and reducing glandular vascularity. Contraindications for this is toxic multinodular goitre. So toxic multinodular goitre, remember the mechanism here, it is autonomous, not autoimmune. Okay, so toxic multinodular goitre is a contraindication for the use of Lugol's iodine. You should not use Lugol's iodine because it may worsen the hyperthyroidism. Planned radioactive iodine therapy. Okay, critical rule must be given after antithyroid drugs in thyroid storm. So you can give in toxic multinodular goitre in Graves' disease also, in thyroid storm you can give it in these conditions, but the condition is you should give this after 80 days to restore the Wolff-Chaikoff effect. But in toxic multinodular goitre it is contraindicated. Okay, let us see now glucocorticoids. Hydrocortisone or dexamethasone. Hydrocortisone 100 mg IV 3 times daily, or dexamethasone 2 mg IV 3 times daily. So this blocks the conversion of T4 to T3 and provides adrenal support during hypermetabolic crisis. Precautions: use cautiously in diabetics. Why? Because it induces hyperglycemia. Okay, and standard other precautions for steroids should be taken. Next thing is teprotumumab. So the dose is 8 sessions every 21 days. Okay, that is thing. The dose is 10 mg per kg IV. 10 mg per kg IV, then 20 mg per kg IV. Okay, 10 mg per kg IV, then subsequently 20 mg per kg IV every 3 weeks for 21 weeks. For 21 weeks. For 21 weeks, nothing but 8 doses. 21 weeks, you can say there are 21 weeks or 8 sessions. So 8 3 is 24 actually. Okay, the first dose you should give 10 mg per kg, then from second dose you can give 20 mg per kg. It is a monoclonal antibody selectively inhibiting IGF-1 receptor on orbital fibroblasts. Indications for this is active severe thyroid eye disease. Okay, side effects for this is hyperglycemia as a side effect. So it can cause a hyperglycemia. It can cause hearing loss, ear side effect, muscle spasms. So metabolic side effects like hyperglycemia and hearing loss, it can cause hearing loss, and muscle spasms. These 3 side effects are there: hyperglycemia, hearing loss, and muscle spasms. So these are the drugs which we use in hyperthyroidism. Their dosages, indications, contraindications, mechanism of action, everything is given here. Okay, so one point to remember here. So we have discussed that they carry a side effects. So remember, minor side effect is skin rash. Okay, and severe side effect is hepatotoxicity. More than 2 times elevation of the transaminases is severe toxicity of this thionamides. Remember this thing. Okay, so cross reactivity of, one thing to remember is cross reactivity of antithyroid drugs in clinical practice. If a patient develops a minor localized skin reaction to methimazole, cautiously switching to propylthiouracil is acceptable, though cross reactivity occurs in up to half of the cases. However, if a patient develops a severe adverse reaction such as, so these two are severe dose effects, such as agranulocytosis or severe hepatotoxicity on one thionamide, the clinician must absolutely avoid using the other agent in the class. In the event of agranulocytosis, medical management with ATDs is permanently contraindicated, and the patient must be rapidly transitioned to definitive ablative therapy either radioactive iodine or surgery. Okay, so there is a cross reactivity. So if one thyronamide, meaning one ATD antithyroid drug develops a severe reaction, then all of the thionamides are contraindicated. If one thionamide develops minor side effect, then you can switch on to second other thionamide. But remember, in this case also 50% of them develop cross reactivity, meaning the side effect. So this point we should remember. Now coming to the special situations and clinical pitfalls. In that, the first one is management of hyperthyroidism in pregnancy. So in the management, the first thing in pregnancy we need to do is we should differentiate physiological gestational thyrotoxicosis from Graves' disease and true Graves' disease. That is the first goal of our management in hyperthyroidism in pregnancy. Differentiate physiological, there is something called as physiological gestational thyrotoxicosis from true Graves' disease. So let us see what is the difference. So in pregnancy, there is massive surge in human chorionic gonadotrophin, that is HCG. So this causes physiologic transient subclinical or mild overt hyperthyroidism. You will have suppressed TSH, normal to high free T4, and this accompanies severe nausea of hyperemesis gravidarum. That means if a pregnant lady has severe hyperemesis gravidarum, severe nausea and severe hyperemesis gravidarum, you should suspect she may be having hyperthyroidism. Okay, mild physiological gestational thyrotoxicosis. She may be having physiological gestational thyrotoxicosis. So this is dominant in first trimester. This HCG mediated physiological thyrotoxicosis, physiological pregnancy thyrotoxicosis is dominant in first trimester. This biochemically resolves spontaneously by mid pregnancy as HCG gradually declines like this. So till 20 weeks it can be there. After 20 weeks it will not be there. This is important point. Okay, you will not find physiological thyrotoxics after 20 weeks or 5 months. Okay, so clinical pitfall here is misdiagnosing this mild pregnancy induced thyrotoxicosis as Graves' disease. No AD treatment required. ATD treatment is required. Resolves spontaneously. Now, if you have confusion, what you should do? Just go and do the TRAB, thyroid receptor antibody test. If these are negative, then you have ruled out Graves' disease. That's all. Now coming to true uncontrolled Graves' disease. Okay. Two Graves. Now one thing we should know here. So that is one thing. You check the TRAB. If TRAB is negative, then Graves' disease is ruled out. Clinically, how you should suspect Graves' disease in a pregnant lady? So she may be having Graves' disease before pregnancy. That is one point. And normally this physiological gestational thyrotoxicosis will end up in less than 20 weeks. Okay, from 2 weeks to 20 weeks it will end up. It will never persist more than 20 weeks. And if this thyrotoxicosis, if the thyrotoxicosis is persisting for more than 20 weeks, then you should suspect again Graves' disease in this patient. That is clinically I am saying. Now to confirm, you should do TRAB, thyroid receptor antibody. That by that you will confirm this. Okay. Now if the pregnant lady has truly Graves' disease and it is uncontrolled, then that has a severe obstetrical risks. True uncontrolled Graves' disease carries severe obstacles, similar to uncontrolled hypothyroidism. What are those? Spontaneous abortion, premature birth, abruptio placentae, preeclampsia. So one thing is not there. What is that? Cretinism. So cretinism is specifically to hypothyroidism in pregnancy. The spontaneous abortion, premature birth, placental abruption, and preeclampsia. These are the challenges. Okay, if you don't treat Graves' disease in pregnancy. Now, so antithyroid drug therapy guidelines by trimester. So in the first trimester, because there is organogenesis, PTU is the drug of choice. Methimazole is contraindicated. It can cause aplasia cutis and choanal atresia. So after first trimester, you should transit to methimazole in second and third trimester. Transition from PTU back to methimazole minimizes the risk of maternal fulminant hepatic failure associated with prolonged PTUs. Yes, as we learned in the previous video, if you use PTO, it carries a high risk of hepatotoxicity compared to methimazole. And one important thing is agranulocytosis is a very important risk factor in methimazole. So that's why. So because PTO has high risk of fulminant hepatic necrosis, you should switch over to methimazole in second and third trimester. Now, how do you dose? What should be our aim? Remember, our aim in treating hyperthyroidism in pregnancy is to maintain mild hyperthyroidism, mild thyrotoxicosis. This should be the aim. Mild thyrotoxicosis. What that means? That means free T4 should be kept just above the upper level of the normal range. Just above the upper level of the normal range, we should keep the FT4. So that means that is the meaning of mild hyperthyroidism. That is the goal. Okay, so this is very important point. So use minimum effective dose. Okay, target is maternal free T4 slightly above the upper reference range. So this is the goal. Aggressive overtreatment induces fetal goiter, fetal hypothyroidism, cretinism. Goiter, hypothyroidism, cretinism. So don't treat aggressively. Start low, go slow. Start low, go slow. Start low, go slow. So this should be the rule everywhere, not in only here. Now, what are the neonatal risks and TSH receptor antibodies? So TRABs persistently stimulate fetal thyroid, especially in third trimester. So that can cause fetal tachycardia, intrauterine growth restriction, neonatal thyrotoxicosis, requiring postpartum intensive care. So this is when you don't control the meaning. This is there is a risk actually. If you control, also there is a risk, because you are not controlling your these antibodies. You are not suppressing the immune system here. So this can happen. So these ladies have a risk of fetal tachycardia, intrauterine growth restriction, and neonatal thyrotoxicosis. The risk is there in these ladies. Okay, so this should be kept. These are high risk pregnant women. Okay, why that occurs? Because the thyroid TRAB, thyroid receptor antibody, persistently stimulate the fetal thyroid gland. Now the next topic comes is the amiodarone-induced thyrotoxicosis. Remember, amiodarone causes both hypothyroidism as well as thyrotoxicosis. Hypothyroidism, why it causes? It causes hypothyroidism in normal gland, and it causes thyrotoxicosis in abnormal gland. That's all. This is the very simple funda. It causes hypothyroidism in normal gland and thyrotoxicosis in abnormal gland. That's all. Amiodarone, the trigger. So potential class 3 antithyroid features highly lipophilic structure, allowing it to persist in adipose tissue for months to years after discontinuation. This is very important point. It can persist for months to years after discontinuation. 40% by iodine by weight. So it is deposited in the adipose tissue. Okay. Disrupts thyroid function, precipitating thyrotoxicosis through two distinct pathophysiological mechanisms. Depending on that, you have two types of AIT. One is AIT type 1, one is AIT type 2. Type 1 is overproduction, type 2 is destructive or leakage. Simple. So discontinuation of amiodarone is important if cardiac status permits. So this is the treatment of choice in these patients. If cardiac status permits, then just discontinue. If safer alternatives available and you can switch over to that alternative, then just take out your amiodarone. Okay, that is the one. But there in AIH, meaning amiodarone-induced hypothyroidism, don't, if it is controlling well arrhythmia in the patient, then don't cut the amiodarone, just increase the dose of thyroxine. So that was that treatment in AIH. So AIT is different, AIH different. Now in type 1 there is overproduction. What happens? Because the gland is abnormal, there is loss of Wolff-Chaikoff effect. When there is loss of Wolff-Chaikoff effect, massive iodine load because of amiodarone, which has iodine in it 40%. This will fuel the autonomous hormone synthesis, and that will lead to increased cellular synthesis. Okay, so this happens in pre-existing undiagnosed toxic MNG or latent subclinical Graves' disease. Okay, on ultrasound you will have normal or increased vascularity, active ongoing cellular synthesis. High vascularity you will have in ultrasound in AIT type 1, and it is seen in abnormal gland, what I said. Now type 2 is destructive, so leakage. So drug induced direct lysosomal toxicity, severe follicular necrosis and hormone leakage will be there. So that necrosis is also known as dam break necrosis. So whenever a dam breaks, and how the water flows from the dam, so like that the hormones will flow from the follicles into the circulation. So that is known as dam break necrosis by amiodarone. So hormone leakage, and with thyroid with dead patches. So it happens in completely normal normal gland. So if at all amiodarone wants to develop thyrotoxicosis in a normal gland, so this is the mechanism, destructive mechanism. Okay, so it can cause both hypothyroidism and hyperthyroidism. So in abnormal gland it causes your type 1, and in normal gland it causes type 2. How you do differentiate? So this is one normal gland will be there. There will be no disease, no TMNG, no Graves' disease, and on there will be decreased or complete absent vascularity, and that suggests destructive or necrotic thyroid gland. So one thing, clinical pitfall and standard of care. So one clinical pitfall: combined ambiguous AIT, multinodular factory and dam break necrotic follicle. Distinguishing type 1 from type 2 is notoriously difficult in clinical practice. So this point is important, very important. Distinguishing type 1 from type 2 is notoriously difficult in clinical practice, and mixed presentations occur frequently. Okay, so what is the funda there? The funda is you should give combined regimen, that is the standard of care, stabilizing patient heart and hormone chart. If the specific type remains uncertain, the standard of care involves initiating a common combined regimen of both high dose methimazole and high glucocorticoids. High dose methimazole and so what do glucocorticoids will do? Glucocorticoids will suppress the inflammation, the destruction caused by amiodarone. Okay, and methimazole will suppress the excessive production. That's how. So high dose methimazole along with high glucocorticoids until the patient stabilizes and the clinical picture clarifies. Now one question will remain: how do we know that the clinical picture is clarified? So one thing is this, as I said, whether the gland is normal or abnormal gland, and on Doppler ultrasound what is the state of thyroid gland. That is the one picture. So normally mixed type of picture is seen, and you should start methimazole along with glucocorticoids. Okay, high dose glucocorticoids with high dose methimazole. But after treatment If you slowly remove glucocorticoids and the thyroid hormones are not increasing, that means it is type 1. So continue methimazole. Or in other words, if you decrease the dose of methimazole and the thyroid hormones are not increasing, then that means it is type 1. Then continue methimazole and discontinue glucose. That's how you should decide. Other method is do ultrasonography. If there is vascularity, that is type 1. If there is no vascularity, that is type 2. That's how you manage amiodarone-induced thyrotoxicosis. Type 1, type 2. Normal gland, abnormal gland, normal gland. Vascularity, no vascularity. So combined regimen is the standard of care. Now this is also very important, and this is the last point. Management of subclinical hyperthyroidism. Subclinical hyperthyroidism. What is the definition? Suppressed TSH less than 0.1 milli international liters per liter, and free T4 and free T3 will be normal. So this is subclinical hyperthyroidism. Clinical pitfall. Consequences of undetected or untreated subclinical hyperthyroidism. What will be the consequences? The consequences will be on heart and on bone. So there will be persistent atrial fibrillation or refractory atrial fibrillation. And second one is there will be accelerated bone resorption. So if you don't treat subclinical hyperthyroidism, atrial fibrillation probability will triple. Nearly triples the incidence, particularly in the elderly demographic. And on bone, it significantly accelerates osteoclast-mediated bone resorption, early onset osteoporosis, and debilitating fractures. The most common error is dismissing this as benign or irrelevant. Okay, so how to intervene? So the American guidelines. Active therapy is recommended if the patient is older than 65 years of age, because they have a very high cardiovascular risk, and risk of fractures is very much high. That's why more than 65 years of age, start therapy for these patients, even though T3 and T4 are normal. Okay, but if the patient is not elderly, meaning if the patient is less than 65 years of age, so now terms and conditions apply. If the patient has one of the three, 1, 2, 3, similar to subclinical hypothyroidism, if the patient has significant cardiac risk factors, or documented osteopenia, or symptomatic nodular disease, then you can start therapy in these younger patients also. Cardiovascular disease, documented osteopenia, heart, bone, and then nodularity of the gland. If one of these is present, start the therapy. How you will start? Usually involves low dose methimazole you should give. Okay, or second thing is targeted radioactive iodine therapy you can give. So this is the treatment of subclinical hypothyroidism. Just to revise, what is the what is the treatment of subclinical hypothyroidism? In subclinical hypothyroidism, the treatment depends on the level of TSH. So if TSH is more than, I will take the white one. See, in subclinical hypothyroidism, just to revise, subclinical hypothyroidism, so possibilities. If the TSH is more than 10 milli international units per liter, then treat across all ages. So that is the thing. But if the TSH is not more than 10, if the TSH is less than 10, then here age will matter. Now you will see the age. Okay, if the patient's age is more than 70 years, then you will have a wait and watch policy. Why? Because normally TSH increases in elderly patients, but it will not go more than 10, it will be less than 10. Okay, the second condition is the age is less than 65 years. Okay, age is less than 65 years. Then here terms and conditions apply. What are the terms and conditions? 3 conditions. Again, high cardia, there is a patient is already known of coronary artery disease. Okay, one thing, this is the one. Second thing is patient has metabolic syndrome. So metabolic syndrome, particularly if the TSH is between 7 to 10 milli international units per liter. So TSH with metabolic syndrome, TSH with this level and metabolic syndrome, start the therapy. In subclinical hypothyroidism talk, this is what subclinical hypothyroidism. Okay, or if there is dyslipidemia. Okay, so patient has a coronary artery disease, or patient is dyslipidemic, or patient has history of metabolic syndrome, then you should start the treatment. Or one more thing is patient is symptomatic. Patient is symptomatic and has specific symptoms of hypothyroidism, then also you should start treatment for these patients. So that's the thing. In hyperthyroidism, if the patient is elderly, more than 65 years of age, start the therapy. If less than 65 years of age, then terms and conditions apply, like that. Okay, that's the end of this topic. Thank you for your listening.